Welcome to UOA On Demand. Today we'll be discussing shoulder arthroplasty. We have three of our upper extremity specialists at UOA here with us today. So Dr. Tim Leddy is a hand and upper extremity specialist at UOA, along with Michael Liu, who specializes in shoulder and elbow surgery, and myself as well, specializing in hand and upper extremity surgery. So with that, why don't we begin talking a little bit about shoulder arthroplasty. I thought something that we could first answer would just be describing what is a shoulder replacement.
The total shoulder arthroplasty, or standard arthroplasty of the shoulder, is a replacement that takes away the arthritic portions of a shoulder that's been damaged over time from degenerative disease, or perhaps even post-traumatic arthritis after injury to the shoulder. So the surfaces of the joint become damaged to the point where it's painful to move, it can be limited in motion, and we need to resurface those areas. And we do that typically with a combination of metal and plastic. And thereby we can put a new ball and a new socket in place that has smooth surfaces and allows for easy gliding and a significant decrease in pain.
Okay. And then there's different types of shoulder replacements. Mike, maybe you want to talk a little bit about the different types?
Sure. Right. So as Dr. Leddy alluded to, the shoulder's a ball and a socket joint. So one of the easiest shoulders to think about is an anatomic shoulder replacement, which would be replacing the ball with another ball and replacing the socket with another socket. So that's an anatomic, where you're just replacing exactly what you took out in the first place. There's another replacement called a reverse shoulder arthroplasty, which is when you reverse the ball and the socket. You're putting a ball where the socket is and a socket where the ball came from.
Right. And then, so what are some types of, what are some reasons why a patient would get one over the other?
Yeah, I think the most common indication that I see for shoulder replacements, at least the anatomic version, would be osteoarthritis. So older patients who have just wear and tear that develops over time, and they develop pain, limited range of motion. They develop crepitus, which is this kind of grinding or clunking sensation in the shoulder. And they have pretty classic x-rays where they get bone-on-bone arthritis, joint space narrowing. So those people tend to benefit from anatomic shoulder replacements. I find that the biggest benefit of reverse shoulder replacements can be found in patients who have a missing rotator cuff or a massive rotator cuff.
Okay. And then do you do those reverse replacements in patients who so just have the rotator cuff tear, or sometimes if they also develop arthritis, or what's your patient population like who undergo reverse shoulder replacement?
Yeah, so I think it's a mix. Just like you said, patients can have arthritis with the rotator cuff tear. Sometimes they just have a massive irreparable rotator cuff tear, and some can sometimes have what we call a pseudoparalytic shoulder, meaning their shoulder can't be raised overhead by themselves, so they can't actively raise their arm on their own. But if I come along and I examine them, then I can move it for them. So their shoulder behaves like it's paralyzed, but it's really just because they have a massive rotator cuff tear that doesn't allow the shoulder to move normally. So those patients can benefit from a reverse shoulder replacement, even if they don't have arthritis.
Okay. And then, Tim, any other indications that you know of? Like, I mean, I guess one of the questions that comes up is, so a patient that has maybe poor function, but doesn't have much pain, you know, how do you address that type of patient? Or, you know, do you look for both pain and lack of function to become a candidate for a shoulder replacement?
You know, that's a really excellent question. And, you know, clearly the number one indication for doing any kind of shoulder replacement, regardless of the variety, is going to be pain. Function, however, is an important second pedal to that. And they usually are going hand in hand. If you have, you know, significant loss of function, loss of motion, those people are going to be restricted, and some of that restriction is going to result in some discomfort or pain if they get to the extremes of whatever that motion will allow. And so frequently it's a hand-in-hand thing, but is the occasional person that you'll see that does not have a significant amount of pain, And depending upon their place and station in life, it may not be the right idea to replace that shoulder. They may be better off with some limitation in motion, realizing that, pain is not a huge issue for them, and not take the risks that are associated with the surgery to do that. That again, it depends on where they are in their state of life. If you have somebody that's, they paint murals and that's all they do, they need to be able to reach over their head to make that painting happen, and they don't have much pain, but they can't get their arm up over their head. That may be the patient that decides that even though pain isn't their major priority, they want to have that return of function so they can do overhead activities. And I think that has to be taken into consideration.
Yeah, that's a great point. If you look at it more like a quality of life issue, whether it's pain that's affecting their quality of life or their lack of function, I think the shoulder replacements do a really good job at restoring quality of life if it's really if the shoulder's really giving them a big problem in that regard. So all right, well, that's great. And then what about so if a patient decides to go ahead with a shoulder replacement, anything you guys are doing before surgery, like medical clearance or any special imaging before doing the surgery?
Well, you made a good point about, deciding between a standard arthroplasty or a reversed arthroplasty. And I've become a big fan of wanting to know what that rotator cuff looks like, not just if it's torn, but if it's been deconditioned or if there's atrophy associated with that. And that may lead me more towards doing a reversed shoulder than a standard arthroplasty. So I'm a big fan of getting preoperative MRIs for the majority of the patients that I'm going to consider a total shoulder for. I think for the patient that has significant degenerative change, where there's potential bony loss of bony construct, if you will. I mean, normally there's a size and shape that's associated with the ball in the socket, and over a grand period of time, with longstanding arthritis, that can actually be worn down to an abnormal shape. And that's an important consideration to look at preoperatively. And that's normally done with a combination of X-ray and CAT scan, so that you can better be prepared to replace that shoulder in a way that's going to be most stable, have at least chance of failure. So preoperative imaging is really three major things: plain X-ray, MRI to evaluate the rotator cuff, and if needed, a CAT scan, so that we can get really good three-dimensional bony anatomy and an understanding of this. This is a complicated joint. It's a very large ball in a very small socket. It's inherently unstable, and it needs to have a really good found understanding for where those components need to go, so that we can properly balance the soft tissues and create stability of what is normally an unstable joint.
Right. How about you, Mike? Anything else to add to that?
Yeah, so just like Dr. Leddy said, start with x-rays, MRI. Jamie, I know you sent over that PowerPoint slide where you showed some preoperative planning. I'm not sure which system you use, but the one I use does go based on CAT scan. So I'll typically send patients for a CAT scan of the shoulder, and allows three-dimensional templating that we can get exact, specific guides made for the patient, custom guides, so that I can position the implants exactly where I want them. Okay.
Yeah, I find that's helpful. And really, it enables us to do the surgery on the computer before getting to the operating room, which I find helpful too.
Jamie, you mentioned one other thing: the medical clearance. Many of the patients that need shoulder replacement, or any joint replacement for that matter, they tend to be a little bit older. And as a general rule, I think the majority of those patients are getting some form of medical clearance, so that we're not operating in a vacuum. We like to have the entire medical team on board, so that all the T's are crossed and I's are dotted, to make the safest transit through the operating room as possible.
Yeah, I agree. I think a lot of times we get patients and they'll come in and they'll be like, "Oh, I'm too old for shoulder arthroplasty," and I think it's important to let them know that there's no real age limit for shoulder arthroplasty, and like Dr. Leddy said, as long as we're the medical team, their primary care doctor, their cardiologist, or whatever medical team they have is on board, then we usually can proceed with the surgery. So, all right. And then, so the patient decides to go ahead with surgery, and what are you guys doing? Or do you usually admit the patients for a night after the surgery, or are some patients going home the same day?
I think it depends on the individual patient. I find that older patients who have more medical problems probably do benefit from an overnight stay in the hospital. At least that way someone's there to keep an eye on them. Potentially if they have social issues at home or they need help at home, then you have the nursing staff available, and I can come by and see them the next day as well. Versus possibly younger patients, healthier patients who have more help at home, they can go home the same day sometimes, especially if they have a good nerve block. So they go home, they don't have pain until typically the night of surgery, and then they can take their oral pain medication, put some ice on the shoulder, just kick their feet up, watch TV at home.
Mhm.
Yeah, I like doing them as outpatients. I've had, very positive experiences with that. But there's going to be the occasional case where it just makes sense and is a safer thing for an overnight stay. And if there's ever any question, we just keep somebody. And I think that's a reasonable approach to make. I also think that some of it has to do with timing. We like to do these cases first thing in the morning when we can. That's not always a reality. If the case doesn't go until later in the afternoon, I'd prefer that a patient stay. We do like to keep them in the recovery area for a while if they're gonna go home, and make sure that they're really doing okay and their pain is controlled before they just zip out of the surgery center. So it really does depend on timing a little bit as well.
Yeah, yeah. I definitely I feel the same way. With in terms of with pain, also making sure the block works well is important for them to make the transition home. A lot of times patients sometimes ask me, they've had other joints replaced like their hip or their knee, and they ask to compare a shoulder replacement pain compared to either the hip or the knee. What do you guys have a thought about that? I mean, obviously I don't think you guys have had those replacements yourselves, but just in terms of getting some feedback from other patients about comparing it from a pain perspective to other joints.
Yeah, I think.
Go ahead.
Sorry, go ahead, Tim.
After you.
Thank you. So speaking with the hip and knee guys, it seems like the anterior hip replacement is a game changer. So people love anterior hip replacements. They're getting up and they're walking out of recovery, and they're loving it. Pain is significantly improved relative to the traditional kind of posterior hip replacement that I was trained on way back when. And patients love anterior hip replacements. So I'm guessing there's going to be a UOA on demand about anterior hip replacements at some point. But so anterior hip is relatively not pain-free, but patients approve of that in terms of pain. I think shoulder replacements are probably more painful than that, but less painful than knee replacements.
What do you think, Tim?
I guess.
Again, I think it's a good question. And as a general concept, I would agree with Mike on that one. The thing that I would add is for the shoulder, people can tolerate shoulder arthritis typically for a lot longer than they can hip or knee arthritis. And for those patients that have lived with it longer, they tend to have some pretty significant contractures that can form. And in order to replace that shoulder and get it, a reasonable amount of function out of it, it requires doing some soft tissue releases and some balancing of those soft tissues. And so, of course, the more invasive the surgery, you can expect the more painful, that recovery can be. And so for those folks with the big, large osteophyte, we have to really struggle to get the soft tissues loosened up to allow for that motion. They tend to have a significant amount of pain. Now, the blocks have been a bit of a game changer. When I first came into practice, we didn't use a whole lot of blocks. And for those patients that had shoulder arthroplasty requiring significant releases, they were at the top of the list of pain for a while. With the blocks in place, and particularly a longer acting block, many of our anesthesiologists put a block in now with a catheter that can provide pain relief through that catheter for 3 days without the need for significant narcotics. That has been a change for the shoulder in my patient population. And there's still some discomfort involved with the surgery, but it's amazing to me how some patients, particularly those that don't need the big soft tissue releases, have significantly less pain after the surgery because they don't have the arthritic pain anymore. And so, yes, they have some incisional pain, but if they didn't have a whole lot of dissection to get in and out of there, they're pretty comfortable pretty quickly after that surgery. So for me, it really depends on how aggressive we have to be releasing the shoulder during the process of implanting the prostheses.
Right. Yeah, that's definitely a good point. Each patient is different and brings different complexities
Yeah,
to the
and
walk.
many of these patients will talk amongst themselves, and you'll hear stories of people coming in saying, "I never want to have my shoulder replaced because my friend Johnny had it done and he
Right.
never stopped complaining about it." And then somebody else said it, so I can't wait to have my shoulder done because this person had it done and they flew through it. And you have to really emphasize that to the patients. Their experience is going to be unique. It's not easily predictable either. Some things can be predicted, but not all of them.
Right. Absolutely. All right. So the patients have their surgery. They make it home. I guess without getting in too much detail about the post-operative protocol you guys follow, I guess just one simple question would be, how long do you keep your patients in a sling after surgery?
Yeah, I typically keep my patients in a sling for 4 weeks. They're doing physical therapy during that time. People can, it's a sling to text, they can type. If they have a desk job, they can typically go back to work after a few days or a week or so and work at their desk job, but really not doing too much with that operative extremity. So it's limited with that particular arm, but they can typically get by.
I do a slight modification of that. As soon as a block is worn off, I let them take the sling off unless there's been some extenuating circumstances. I want them to start moving the shoulder with what we call a pendulum range of motion, just simply getting it moving and essentially lubricating that joint. I do like to move them earlier than many other docs, but I still would have them wear the sling when they're quote unquote out and about, or when they're, when they're, I like to use the term when their mind is elsewhere. If they're going to be at the supermarket and they're thinking about all the things they need to get, I prefer that they have a sling on for that, so they're not reaching into a position that may be uncomfortable or detrimental to the healing process. If they're at home or at their desk, as Mike was saying, they can take that sling off quite early and give the neck a break, so to speak. If they're wearing that sling all the time for 3 weeks, they come in complaining about the neck pretty good, and it's sort of nice to be able to get them in and out of that. Now, that can't be for every case. There are some cases where we just simply have to be more strict about keeping them in a sling. A lot of that, again, has to do with the soft tissue repair on our way out. If there's questions about how good that repair is going to be and the quality of the tissues that we're suturing back together, then I'm going to be more kid glove with those patients.
Right. Yeah, I usually keep patients in a sling for about 4 weeks. Also start therapy early. Try to have them do pendulums as well at home on their own. So, and then patients usually want to know when will they start really feeling better? When will they start using their arm again? Where it feels like it did before all this arthritis that they had. What do you guys usually tell your patients when will that occur?
I'm pretty bold about the statements regarding the recovery. I come right out front and say they're going to be, involved in this process for a year. It's a calendar year as far as I'm concerned. And I can simplify it and break it up into smaller pieces, but essentially the first 3-month block is a combination of letting those soft tissues heal, letting the component grow into the bone, because the humeral part, the ball, if you will, has some ingrowth that needs to occur so that there's good stability to that. And that's that first 3 months. During that period of time, we're dabbling in getting their range of motion back, but we're really letting the body heal. The second 3-month block is kind of establishing and finishing off getting the maximums of motion. And of course, during that 3-month block, we start to dabble in the strengthening component. And then the next 6-month block that fills out the year is really getting their strength back, because they've lost a lot of strength prior to getting this surgery done, and they lose even more strength during the process of getting it done. And so building that back up tends to be a year-long process. And again, that doesn't mean they're not feeling better, earlier or right away. The pain of the arthritis is gone a lot earlier. They're in many cases more functional because they have a better range of motion. But to really get to a point when they're beyond and they're feeling like they've got that shoulder back, it's, I think, important in my mind to have them have that year block in their head that that's what it's going to be.
Okay.
Yeah, I think Tim brings up a good point where people who have bad arthritis, limited range of motion, poor function, can't sleep at night, after they have the surgery, within the first few days or week even, they're feeling different. sometimes they're sleeping better, the pain is better, their function isn't great yet because they're still fresh post-op, but it's just a different type of pain. And so a lot of people will come in and say, I still have pain over my shoulder where the incision is, but it's not that deep sort of nagging pain that keeps me awake at night anymore. So I think people do respond to shoulder replacements for arthritis pretty quickly, but like Tim said, it's a process where you have to regain your motion, regain your strength, and then just try to put the finishing touches on. So I typically tell people 6 months to a year for maximizing your outcome.
Yeah, I would agree with that, with everything you guys said with regards to that.
What, not to take away from your position, but what do you guys think about recovery from anatomic replacements versus reverse replacement?
I would say that I think the recovery may be a little quicker with a reverse, just because I usually get them moving a little bit earlier, because you don't have to worry so much about the part of the rotator cuff that you take down to heal itself as you would with a regular shoulder replacement. So I don't know, I think it may be just a little quicker with a reverse.
Yeah, I would agree with that. Again, it's generalizations a little bit. I certainly have had patients where I've done a reverse on and their recovery was a much longer process. And that again comes into that individuality of each patient and their experience. But as a general rule, the reverses tend to move a little bit faster. I let patients move at the rate that seems to be comfortable for them. Sometimes we have to back all that, and they're doing comfortable. If they're comfortable, they're doing well, and they're getting their motion back. I try to encourage that.
Any limitations that you guys put on your patients for, after everything's kind of healed and they have good strength and good range of motion and they're pretty pain-free, they want to get back and, they want to get back to the golf course or maybe even play doubles tennis? What do you guys think about that?
I tend to tell patients that because we're replacing their own native joint with a joint made of metal and plastic, that it does have a life expectancy, just like the wheels on your car, or the tires on your car, or the brake pads on your car. The more you drive, the harder you drive, the faster those parts are going to wear out. So I think shoulder replacements, 9% plus can last 10 years or more. So I think it's a good surgery that has good longevity, but the more you use it, the faster it does wear out. So obviously doing a shoulder replacement, the purpose is to improve lifestyle, quality of life. And if you're going to put all these restrictions on them, maybe it doesn't make as much sense to do the replacement in the first place. So I do tend to let people do whatever they feel comfortable doing, with the caveat that the more they do, the faster it might wear out.
You think with some of the modernization of the plastics in particular, I think the survival rate that we're going to see in the future, and of course this is a prediction, is going to be better than what we have seen in the past. And I think that 10-year mark that Mike references, I think is a good number. It's an accurate number with today's data that we've referenced, but I think we're going to see that extend out a little bit longer with the newer plastics and the way that they're managed. But I would agree. I mean, I do tell patients the same thing, is that if they're going to be really hard on it, there's more risk for some form of failure, whether that's a periprosthetic injury because of a trauma, or and periprosthetic, a fracture or an injury around the prosthesis that requires, some sort of revision. That can be a big deal. And then just the wear and tear on that shoulder. The only other thing that I would mention would be the timing of that. Again, I mentioned earlier that there needs to be some bony ingrowth with many of the components that we're using. And that tends to be a 3-month process in my way of looking at things. So for the guy that wants to, he's chomping at the bit, so to speak, to get out on the golf course, I'm going to let him go and pitch and putt, but I'm not going to let him take big, heavy, jarring swings at a ball until I'm pretty confident that thing is healed in well. And that bony ingrowth has had a chance to set up quite a bit, or they're doing any kind of really heavy contact. And a good criteria that, and Mike referenced this already, but you need to have a reasonably good amount of motion in that shoulder. You need to have reasonably good strength of that shoulder. Your pain need to be under control. And your nerves need to be functioning. And for most people, they get the nerve one for free. Their nerves are usually okay before and after the surgery. And so meeting those criteria, the ones that I use, and explain that to patients. And they, after you've gone through that with them, they tend to agree with you that, yeah, they're not ready for that particular activity once they've sat and thought about all those different things.
Right. All right. Well, anything else you guys want to mention that maybe you get frequently asked in the office by patients regarding shoulder arthroplasty?
I think, we didn't touch on it, but I'm not sure it's necessarily apropos, but every once in a while, we'll see somebody with a really bad shoulder fracture that we will then consider doing a replacement of some sort on it, whether that's a partial replacement, we call the hemiarthroplasty, or a total shoulder replacement. Bad traumas to the shoulder, or we think that that joint is not going to be recoverable. That's another indication to consider shoulder replacement surgery.
Definitely.
I think some other questions that patients do ask about whether or not they'll off a metal detector at the airport, and they will. So you give them a card, get on the airplane, not a big deal. Other patients ask about antibiotics when they go to the dentist, and typically they have another joint replacement, so they already know about it. They're getting antibiotics anyway, or if they don't have another joint replacement, I can give them a prescription for antibiotics. But I do think it's important to get antibiotics before dental procedures if you have a joint replacement.
And you guys do that for life? I usually prescribe, for the rest of their life with the joint replacement, just because I've seen infections sometimes occur around dental work even years later. So, but I know that there is some data to suggest maybe you only have to do it for a year. So there's kind of some different opinions out there.
Yeah, I think the jury's still out, so I kind of err on the side of caution and get antibiotics for life for the dental work.
Well, this concludes our talk on shoulder replacement surgery. Please feel free to visit our website at uoanj.com if you think you may be a candidate for a shoulder replacement or have shoulder pain in general. We would be happy to see you. A special thanks to Dr. Leddy and Dr. Liu for their valuable insights on shoulder replacement. Thank you very much.